Hi there. So I know everyone is still filtering in and getting some food, but we're going to get started because we do have a limited amount of time. And just a few housekeeping items. There's QR codes on your tables, and those are both for the evaluation, but also to be able to look at the polling questions that we have. And we were just commenting on what a great turnout this was, but I know you all just came for the free delicious wraps. So feel free to keep eating those and getting more as you need to, but we're going to go ahead and get started, just in the interest of time, because they've already started our clock that we can all see ticking down. So before we start, I just want to start with a land acknowledgement. So I want to acknowledge the land that we're currently meeting on. It's the traditional land of the Anishinaabe, the Haudenosaunee, the Lenape, and the Attawandaron. These lands are connected with the London Township and Samba Treaties of 1796 and the Dish with One Spoon Covenant Wampum. This land continues to be home to diverse Indigenous peoples, including First Nations, Métis, and Inuit, who we recognize as contemporary stewards of the land and contributors of our society. For disclaimer, so this is funded by Gilead Sciences, but we're allowed to say whatever we want, is basically what that means. So for the objectives for the symposium, so we want to talk about just really, what's happened in the last number of years in HIV, the breakthroughs, strategies, best practices. Certainly for me, HIV has changed over the last 20 years that I've been practicing. Assess some of the inequities in HIV care. We know they still exist. And discuss some community-led approaches and initiatives to inform our responses to the HIV epidemic. And so I thought I'd start with some introductions of the panel and the group, but rather than the boring, we just go through all of our names. I'm going to throw it over to everyone on the panel to introduce themselves and to give a little description about why they're working in HIV or what drew them to the field, what happened, and really why we do this work. So we'll start down at the end.
Hi, Markentin. I'm a family physician and an addictionist from Saskatoon. I actually went to medical school last century. Even though I still look 29, I know. I remember in residency seeing an inpatient with end-stage HIV/AIDS, who's an immigrant from Africa, and we were torturing this young man by doing a bone marrow biopsy for whatever reason, because we didn't know what else to do. And I remember going home that day thinking, man, there's nothing we can do. And then life got in the way, and I was a rural family physician for 15 years, and then I moved back into the city and started doing inner city medicine. And the advances from med school to 15 years ago were fascinating. And I work with this population partly for the addiction, and in Saskatchewan we have a 50% of our HIV positive people have substance use disorder. And it was just a natural way to go. And the advances are amazing. There's few illnesses or diseases in medicine where we can actually make a difference. And in the last 20 years, man, this is amazing.
Hi, I'm Linda Robinson. I'm an HIV clinical pharmacist. To start my story, I guess we have to flash back to 1985, 40 years almost ago. I'm a new graduate. I'm working in Toronto General Hospital. I'd been assigned as a clinical pharmacist to an infectious disease floor. And my very first patient that I present to my colleagues as a clinical pharmacist for real now, is somebody who's dying of AIDS. And I just want to share with you an image that has been burned in my brain ever since that day when I went in to meet this patient, and the room just has this yellow hue around it because everything was biohazard and everything was just, like, be careful. It was still very, very frightening. The person in the middle of the room was so alone, dying, suffering, emaciated, 42-year-old man with nobody there. I think he died the next day, and it was just, like I said, it's some things you just never get out of your head. And in the meantime, down in the Eaton wing, we were giving out study drug, AZT, in white envelopes, and things had just recently gone from being HTLV3 to now HIV and AIDS. And anyways, but then you know, life happens, I get kids, I move forward, flash forward 10 years, and I'm back in my hometown of Windsor, Ontario, 3 kids later, starting back into clinical hospital pharmacy again. And I'm tasked with the idea of involving pharmacists into the care of HIV patients. And why? Because now we have these treatments, but these treatments that are large quantities of drugs, many times a day, a lot of drug interactions. Pharmacists should be involved in care, but it wasn't always part of multidisciplinary care. So I was really passionate about fighting for our right as an integral care member of the team. And I was tasked with the idea of trying to get a program in place to get a pharmacy that would fund a pharmacist to become part of the team. The rest is history. I did that for the remaining 25 years of my career. Fell in love with the science, fell in love with the social side of it, the global side of it. I will tell you for sure, you get to my age and you can look back at your career and say, what makes the difference and what was, I can tell you for sure that I have learned way more from the people that I have come in contact with who are affected or living with HIV or working with HIV than I ever was able to teach them. And I feel very honored and blessed, and even though I'm semi-retired now, I still feel I want to share that passion and that information and education and that legacy, which is why I'm here today.
Hi, I'm Cécile Tremblay, bonjour. I'm an infectious disease medical microbiologist at the CHUM in Montreal. I was a nurse when the HIV epidemic started, and I was witnessing in the hospitals, first of all, that we didn't have a lot to offer to people who were affected, and I was witnessing also the stigma that was mainly driven by fear of things that we don't know, that we don't understand. So when I decided to go into medicine, and I did my medical school and then applied to the infectious disease program, my sole motivation was to try to find answers to these questions. And by better understanding this disease, better understanding what these people were living through, to try to advance the science and advance the care for people living with HIV. And that's what I've been doing through my entire career. As I went to Boston to do a postdoctoral fellowship, I didn't know that I would go this way, but I started to do basic research, laboratory research, which was not my background at all. I was more of a clinician. But then I got interested by the science, and when I came back, I've been navigating from one type of science to the other all my career, doing clinical work, doing basic science, and hope that all this work contributes to the advances that we are going to discuss today. But I still see the need to continue because if we're talking about zero compromise, there's still a lot to accomplish.
Hi everyone, I'm Vimbai Munonyara, so I am the manager of HIV and Hep C client support services at Regional HIV/AIDS Connection. That's a mouthful. It's an AIDS service organization located here in London, Ontario. I think when I think about why I do this work, I am from Zimbabwe, so I moved to Canada 7 years ago. I come from an epidemic country, Zimbabwe, and for me, my why to HIV was AIDS. AIDS was the face of my aunt that I found at the age of 13 on the floor in the bathroom. My uncle who found out he had cancer and gave up. But also the why is, look how many years we've come to today, and HIV is now a new face that I look at, whether it's my colleague turned friend who's down the hall with me at the office, or an executive director that has lived and living experience. And all the clients that come through our doors that we meet and are able to provide services for, but also come in and structure what they want to see. That's my why, and it evolves every day.
And I'm Kevin Woodward. I'm an infectious disease physician at McMaster in Hamilton as well as in Toronto. And when I was a teenager in the 90s and early 2000s, HIV was everywhere in the news. There were billboards up. And as I was coming out, I know a gay HIV physician. It's the only one who exists, I'm sure. As I, dealing with all of those messages in the news as you're coming out and then going to university and medical school, I just gravitated towards this because this was my community that was affected by and living with HIV. That was where I had my mentors. A lot of the physicians that I worked with were people who were from the community and providing HIV care, and I just gravitated towards that, and then have spent the last 20 years doing HIV and now, excitingly, also HIV prevention work. So that's the why for me of why I do this. The obligatory disclosure slide, we all take money from everyone. And so we're gonna first talk about how far we've come. So what are the advances in care? And I think this will be a review, but when we think about our UNAIDS targets, so we know that we had the 90-90-90 goals, and now that's been adjusted to now 95-95-95. We've had massive advances, but how far have we come and where do we have to go? So the first section of those goals are we reaching at-risk individuals? So people who are living with HIV infected, are we able to get testing out to the people who need it and reaching those folks and connecting them to care? So I'm going to first hand that over to Dr. Tremblay to talk about.
So, of course, we've done a lot of progress, as you can see with the graph. But in 2020, there were still 1,520 new infections in Canada, which gives it a rate of 4 per 100,000 people. Some can say it's slow, some can say it's too much, but when you look in 2022, 2 years later, the rate has increased, 4.7 per 100,000. And we've just seen in the last couple of years huge increases in new HIV diagnosis in Montreal. It hit a 10-year height in Montreal. And we see also similar situation in Saskatchewan, where Maurice is going to talk about.
So sadly, we've owned this map for the last 15 years. And I struggle with what I was going to say today, because if I have the answer to why we have rates of 19% per 100,000, some from the crowd might say, well, then why don't you fix it if you know the answer? And then that would exceed the capacity of my antiperspirant, and everything would kind of go to hell in the handbasket here. But we do know the answers, and we could blame it on COVID, and we can blame it on resources, and we can sit here and whine and complain, but the real issue is multidisciplinary, multifactorial, why we have rates of that in Saskatchewan. And in the last 5 years since COVID, we've actually seen a shift. So previous to COVID, our rates were 80% in the IVDU world and only 20% sexual transmission, but now it's switched to 50-50, which again is disappointing because we have PrEP and we have treatment. Why are we still here? And I think we can blame it on resources, we can blame it on racism, we can blame it on stigma, we can blame it on poverty, and we can blame it on homelessness. And it's easy to find a scapegoat. We can blame it on our government. The governments often have an animal. So the Republicans have the elephant and the Russians have the bear. In Saskatchewan, our governmental animal is the ostrich. And our government, which has been long running for 10 years, has its head in the sand. And we have tried and tried to make a difference. And I'll quit there because I'm running out of time, but I have more comments later.
Okay, but we do have good prevention tools. We all know that PrEP is very efficacious, but the problem is how many people have access to PrEP. We've seen an increase in the uptake of PrEP, a 2.9-fold increase from 2018 to 2022. But if you look at the ratio of the uptake of PrEP in people who need it, we only see that there is 31% of people who need it to really access PrEP. And this study from Ontario, from the Engage cohort, I'm sorry, it's a pan-Canadian cohort, showed that you know, it's not because of the lack of knowledge, because you look at the first column and people are aware of PrEP, but they don't necessarily feel that they have a need for PrEP, and when they do want to try PrEP, they have difficulty accessing it.
So I think, you know, if we think about the other end of the targets, so of those in care who are suppressed, this is the area where we're actually doing pretty well. And you'll notice that we're bookending here. We talked about the beginning and the end, and we skipped the middle, and that's because we're going to spend a lot of time in the middle because that seems to be where the biggest challenges are. But if we get someone into care, then we do a good job of getting them suppressed. And you can see that here, where you see that, you know, where we're missing people. If we think about those 95, 95, 95 goals, we're missing the boat about a quarter of the time. So 26% missed opportunity. But actually the majority of that is in getting people diagnosed, getting people connected to care. If we can get folks connected to care, then viral suppression follows along quite naturally for the vast majority of people. So the first, we have a polling question for for everyone here, just to ask the question about, you know, we've talked about the successes of HIV treatment. What does long-term success for people who are living with HIV mean to you in the audience?
Qu'est-ce que veut dire pour vous un succès à long terme pour le VIH? Vous pouvez répondre en français ou en anglais.
So we've got answers sort of rolling in. So I think, you know, people are saying suppressed, so long-term success equals viral suppression, and I think that's 100% part of it. But then we see high quality of life, long life, no more stigma. And you know, that's an important point that I think we all are talking about today, that long-term success isn't just the medical, we're suppressing HIV, but it's actually things like a full and normal life, how people are actually feeling from a day-to-day basis, that you're healthy, that you have a high quality of life. So we've got the important medical bits, right? We don't succeed without viral suppression, but that's rather than the end point, I wonder if that's the starting point, right? We have viral suppression and then we move on to all the other pieces, thriving, long life free of disability, U equals U. There's so many pieces to this that are beyond just the medical. So I'm going to pass it over to Linda, and she's going to talk a little bit more about that 95 viral suppression.
Okay, so you know, if you look at this graph, it's basically a little different than the one that Cécile talked about, because it's actually looking in 2020, the prevalence of HIV cases over time, and it looks like they're increasing. So when you first look at that, you want to go like, whoa, this is scary. Why are there so more cases? But what we're really seeing is the success of care is actually leading to many more people living long, happy, normal lifespans with HIV. Now, some of that might be reflected on new people coming to the country and things like that, but I think what the take-home message is if you look at longevity curves, you'll actually see that years ago, the longevity curve for an HIV uninfected individual was much longer lifespan than somebody who had HIV. And those curves, little by little, year after year, just keep getting closer and closer together. And that's because we have such good therapy. And the therapies we detect it early in most cases. We get them on therapy very early on in the disease. So we get the benefit of a nice, strong house of therapy for someone to stay on for a long period of time. So when it comes to the therapy, what the word that we really want to think about is the durability, because we may have individuals who could be diagnosed in their 20s who live to 85 years old that are going to need 60 years of good, durable, easy to take regimens. I can tell you, 30 years ago, that was not the case. The case was far from being easy to take. But now we have, with the second generation integrase inhibitor-based therapies and even some of the newer things coming down, we have the ability to make life much easier and provide a much more durable therapy. Just as just a quick reminder, there's really three major things that are always in play when we want the therapy to last and be as effective as possible. And it's an interplay really of drug, the individual who is taking the drug, and the HIV virus itself. You'll see on the slide that they're color-coded. The light blue are the things that are sort of are the drug's fault or the drug's play in all of this, whereas the mint green will be the patient components, and then of course the viral issues themselves. What you want really at the end of all this is a therapy that is potent, that has a high genetic barrier to resistance, meaning the virus needs to really mutate a lot before it can actually overcome the drugs. And that's a really important thing. That comes down to how the drug is built. In some drugs, they're built very, very, very potently. They're built to be very flexible. They're built to overcome resistance, and we've come a long way with that. But we've also come a long way with abilities for people to adhere, and that's because the treatments are easier to take. And they are a little bit more forgiving if they have a high genetic barrier, just when things like life happens and maybe you missed your pill that day. Whereas we didn't have that much 20, 25 to 30 years ago, but now we have these more forgiving regimens, especially with some of our second generation integrase inhibitors. So the main message from here is that we want longevity because people are going to be on the medication for a while. So it's not, because therapy seems to be easier and there might be an overlying premise that HIV is getting easier to treat. I don't ever want anybody to just kind of water that down. Just because we have better therapies that are easier to take doesn't mean that the disease itself is easier to treat. And we still do have to think about things like antiretroviral resistance. This slide is a little bit busy, but I just want people to realize that we have two different types of resistance. The type that is transmitted, so that means that the virus that infected a body in the first place is actually already carries resistance because it came from an infected individual who has some antiretroviral resistance in their virus pool. So that's what we call transmitted resistance. It tends to be going down, at least with 2016 statistics. The transmission of resistant mutations tends to be getting much lower. But that could be taking a bit of a turn when we start to see more PrEP being rolled out, and so it's going to be very important that we make sure that people who are on PrEP are taking it faithfully, because you wouldn't want someone, for example, which is shown in the bottom part of this graph, you wouldn't want the situation where somebody might be taking PrEP and inadvertently maybe not taking it faithfully enough, and inadvertently get infected with HIV, but the PrEP drugs are also drugs we use to treat HIV, so those drugs may actually keep the new infection sort of hard to pick up right away, and then the longer somebody is on sort of not fully suppressive therapy, they may develop some resistance to those drugs. So it's just important that we keep these things in mind. We've come a very long way. In summary, we do have regimens now that are very effective, and they do have a forgiveness factor when life happens and adherence may not be maintained, some more than others. But we want our therapy to be trusted. We want it to be safe to take. We want patients to feel fine on it and tolerate it so they stick with it and don't miss it. And it certainly needs to be simple and flexible. And I think we've certainly come a long way in that direction. And that's probably why we're doing so well with our 95% suppression rates.
Yeah, and I think, as we saw from the poll, suppression is kind of step one. So I wanted to open this up to people on the panel. And maybe I'll start with Vimbai for this question, is what are the other goals beyond viral suppression? So we've seen we do a good job with that. What's next?
I think I'm so happy that suppression has been achieved, but I think when we look at what it takes to achieve that, suppression could answer that, what then after? We got to have things in place that make sure that that suppression has that longevity. Often we're happy, we have suppression, it's been achieved, but it ends up being something that's happening backward if we don't put those things in place. I find that still those things that we're talking about, I can't advocate enough about that. We need to look at the things that are are challenges and barriers to that access. When I think of people that are using drugs intravenously, what it takes to take somebody to get to just an appointment. Between the time that somebody, say who is a social service worker, has met with them to get to that appointment, that is one element in a day. So when we talk about suppression, we got to really think of all the layers that come with achieving that longevity to suppression.
Yeah, I mean, it takes, sometimes I think from the healthcare standpoint, we think, oh, I've set your appointment, you're going to show up. But it actually takes so much more than that for everybody to, you know, whether it's someone, as you say, someone who uses drugs who needs help to get there, but even a person to take time off work, right? You know, your appointment's at 10:30, you're taking time off of your day to actually come to this appointment. And I think as healthcare providers, we also need to be mindful of that work that someone has where they're coming to see us, you know, even if it's twice a year for the rest of their lives. There's so many pieces that go into that.
A lot of people wrote in the poll the quality of life and being healthy. So we know that viral suppression is not the end of the road, because we know that there still is some inflammation in the body, and that can lead to premature aging in people living with HIV. So I think that's certainly a goal that we are working on, and we've made great advances on that, but we need to have this in mind in terms of our research projects and in terms of giving the care necessary to take care of these other comorbidities. And in that sense, I agree with what Vimbai was saying, because you need to get to a lot of doctor's appointment when you have early cardiovascular disease. You need to, if you have a depression, if you have high blood pressure, it needs to be treated. That it is a burden for the people if you want to have a good quality of life. And of course, I'm not talking about the stigma that stays there, because we haven't cured HIV. People are still living with HIV, and then with that comes all of the stigma that people have to face in the society, housing, insurance, whatever. So viral suppression is the beginning, but we still have much work to do for the rest.
I was just going to state, you know, on the whole theme of the zero compromise, just back from the drug treatment, you know, way back when we compromised because we gave a lot of pills, but it still, the outcome was that we saved lives. So that didn't, we were willing to compromise that. Then we did single tablet regimens about 10 years later, and we made things easier to take once a day, but then we compromised a little bit because those regimens, the virus developed resistance fairly quickly to it if they failed it, like on non-nucleoside-based regimens, for example. I think we've come to a point where, from a treatment point of view, we do have some regimens that we're not compromising much, especially if we keep it easy enough to take, and we keep it the genetic barrier to resistance high. And I think as new things come down the pipe, we have to demand that stays the focus, that the new things are not just new and improved, but they also do address things like they're easier to take, they have a high genetic barrier, they are more forgiving, because that longevity of life on treated for HIV with a quality with that is all one big thing that we have to keep in mind.
And as in Vimbai said, it's more than just the pill. I can celebrate with a patient in my office, hey, your viral load is non-detectable. And they can look back at me and say, yeah, but I have nowhere to sleep tonight and I don't know where I'm getting supper. And my kids are, I don't know where, I haven't seen my kids in 2 years. And we have to think about that. If we don't take a holistic approach to HIV, it's not just a pill, it's about the whole person. And wouldn't that be something if we treated them like a whole person right from the get-go and had that support in place?
Yeah, and I think, you know, for me, one of the things that resonates is around stigma. And especially as a physician and healthcare provider, I think, you know, we actually need to destigmify our care as well, right? So I remember when I started doing HIV clinics, it was, you know, first of all, we were in the basement of a hospital in a corner in a dingy office. It was a big deal, you know, everything was a 6-hour appointment for somebody to come in and get everything done. And actually changing our approach and saying, you know, your appointment for an HIV follow-up should feel like your appointment for your big toe that hurts, right? This is, you have a medical condition, we're going to treat it, we're dealing with it. And destigmifying the actual healthcare portion of it is something that I've really tried to make a point of over the last little while. And if we don't start there, then how can we expect people who are in society who may not know as much about HIV as we do to have less stigma when we are still treating it like it's this thing that's set apart from every other medical disease. So, well, thank you. So the next question for the audience, just another polling question is, we've talked about this idea of zero compromise, and what does zero compromise mean to you?
Alors, qu'est-ce que ça veut dire pour vous, aucun compromis en 2024? Encore une fois, vous pouvez mettre vos réponses en français.
So one of the comments that just came in, that's scrolled away now, but it was that zero compromise means that your needs are met, that you're improving your relationship with your provider, addressing systemic barriers, which I think is super important because if we don't address those systemic barriers, then people can't access the care they need. No drug toxicity, no discrimination in access. Reaching that last 5-5-5, and I think reaching those last percentages is going to take more work and more money and more investment than the first 90 because there's reasons why we haven't, we haven't reached those yet, and we're just going to have to refocus our efforts to reach those folks. Not creating circumstances that create barriers to reaching those. And again, forgiveness and stability thriving. So I think, again, this isn't just the medical care. It's addressing all facets of life for people who are affected by and living with HIV, and zero compromise means just more than suppression. So if we think about how we're going to shape an effective HIV response, not just for people who may live in downtown Toronto, but for everyone, how do we do that? And so when we think about those middle targets that we looked at, so individuals living with HIV diagnosed, individuals on treatment, this is where we're missing those percentages. And how do we reach those who aren't benefiting from the current model? So, if we keep on doing what we're doing, I don't think we're going to quite get there because what we're doing hasn't gotten us there yet. So how do we change our approach to reach those last 5-5-5? And so, we said 5-5-5, but it's actually probably more like 10-10-10. So if we look at the 2020 UN AIDS goals of 90-90-90, haven't really hit those fully yet. We've already increased to 95-95-95, but we're certainly not fully there yet either. And so there's certain populations where we've done well. Downtown urban populations, we've done relatively well. People who are in federal correction facilities, we've done relatively well with those goals. But for most people, we haven't even hit the 390s yet. And so if we want to increase our response to hit 95-95-95, and then actually really trying to end the epidemic altogether, we've got to refocus our strategy and actually think about what do we need to change in our response to make this more effective. So I'm going to pass over to Morris to talk about some regional discrepancies that we've had.
And so here's another graph that Saskatchewan owns. Thanks, Gilead, for putting me on the spotlight. So why? I mean, and again, we can go over that, but I think since COVID, in Saskatchewan, I think a lot of people, and this is where I'm going to get in trouble, but use this population as an excuse not to care. Oh, they're using crystal meth, so we can't help them. Oh, they're homeless, so we cannot help them. Oh, they won't be adherent. You know what? You show me. I bet you the most adherent patients on the planet are people who use substances. They've proven that. They've proven that they can take a substance every day, multiple times a day. So why are we saying that that's a barrier to care? And I mean, I'm being facetious, but I think we need to just change, if we can change the tact. And I think in Saskatchewan we have a lot of people, but I think they're hampered by the current system and by the current resources. I mean, throughout the years I've spent, I know you look at me and you think I'm a fairly well athletic looking person, but I'm not. I tried out for everything and I spent a lot of years riding the bench. But in Saskatchewan we have a lot of providers who are stuck riding the bench, and if our government would let us on the court, we can make this happen, and I do believe that. So it's not all negative from Saskatchewan. I don't want you guys walking away from lunch today thinking Markentin's HIV spirit animal is Eeyore. It's not, and I get to talk one more time about some positive stuff.
Yeah, so again, if we want to reach those 2025 targets and get to 95, 95, 95, there's populations where we have a long way to go, as I mentioned, and I think, again, they keep throwing Saskatchewan up here for you, but people who inject drugs, we're not at any of the goals yet. We're not even close. ACV populations, we're not there yet for at least the first two goals. And again, First Nations communities in Saskatchewan and in other provinces, we're not there yet. So we again need to refocus and think about what are the strategies that we need to put into place to reach those populations that the goals haven't been serving well. And so I'm going to put it over to Maurice again to talk about marginalized populations in Western Canada specifically. I don't know, Maurice, this is...
So we have a case. Just want to talk a little bit about some of the things that we are doing in Saskatchewan. So a 27-year-old female who comes in with, who's HIV positive and is pregnant at 30 weeks has had zero prenatal care because she has 3 other children in care, and she believes that if she engages into care, this will be her 4th child that will be stolen from her. She's using IV drugs to cope with her life. Again, as I said, no prenatal care, but in Saskatchewan, we have three teams called PORT, or prenatal outreach teams. There's one in Saskatoon, Prince Albert, and Saskatoon. And what they do is they engage high-risk women, whether they're HIV positive or not, but really the highest risk that they're at is of having their child apprehended. They engage this client, they get her into care, they get her to her prenatal appointments, we get her on her HIV meds, and she delivers at 38 weeks with a viral load of less than 1,000. And then her mom and baby are transitioned to our prenatal or postnatal transition home, Sanctum 1.5. Lots of these women, when our team engages them, this is the very first time that someone says to them, would you like to parent this baby? Because for the last 5-10 years, they have been told by the ministry that they are unfit to parent. How does that make you? You're unfit to parent. I mean, I did not win any Dad of the Year awards, and there are a lot of times where I'm sure the in-laws felt that I was unfit to parent, but no one said that to me. But these women, it is said to them every time they're pregnant or every time they want to visit their child that's in care. And we have to stop doing that. And they are in shock when we say to them at Sanctum or with our port team says, would you like a chance with support to try parenting this child? And they think we're nuts. They think that we just got off the turnip truck. We see a lot of marginalized clients at the Westside Community Clinic where I work, inner city in Saskatoon, who had thought that a lovely little city like Saskatoon had an inner city, but it's thriving. And we, 50% of our fully suppressed HIV clients are using crystal meth. And I can tell you that they've had a crystal meth positive urine screen for the past 2 years, but they are still fully suppressed. So anyone that tells me, oh, they're using crystal meth, oh, they have drug-induced psychosis, don't start them. No, start them. Rapid start them, engage them in care right now. And we still have that barrier in Saskatoon. Our graphs are not great, but we are moving. COVID certainly decimated this population. We lost a lot of personal contact in a population that's already stigmatized by the rest of society, and now COVID allowed healthcare to push them to the side and saying, oh, sorry, you can't come in, or we can't do this, or we can't do that, has really set us back 5 years, but I'm hoping we can get back into it. But as I said, a lot of people use this population as a reason not to give them services. And I'm embarrassed that human beings do that, but we know that. So current successes, we have transitional housing and we have safe spaces for this population. We have access to timely addiction medicine. I do rapid starts on a daily basis for buprenorphine and methadone. Sadly, in Saskatchewan, our access to harm reduction supplies has totally changed in the last 3 months. We have the government is no longer supplying pipes and safe supplies, and it's a one-to-one needle exchange. I'm scared to see what the data will show from that. but hopefully we can make a difference after the next election. But we're doing rapid HIV start or ARV starts. We have access to primary care. All of our outreach teams make sure that that patient is connected to primary care. And then we try and re-engage them after we've lost them from COVID. But the challenges continue to rise. Easy access to fentanyl. I can get fentanyl in pretty much anywhere in Saskatoon. If my clients tell me that they can have fentanyl delivered to their door within 5 minutes of making a phone call or text. 5 minutes. Can't even get a pizza that fast. There's increasing crystal meth use, and I think due to the changes in access to the ingredients to crystal meth, I think it's becoming more poisonous. I think our rates of psychosis are increasing, and I think it's due to the dirtiness of that drug, sadly to say. Complex mental health issues and lack of resources. A 2-year wait list to see a psychiatrist when you're drug-induced schizophrenia is unacceptable. And then our homelessness crisis and lack of safe, affordable housing. Some of the affordable housing for our clients on social services, you wouldn't house animals in there. And it's just very frustrating at times. But I think there is hope. I think if we lose hope, then we have nothing. And so we will continue to fight the fight. But we do have good people. We just need to give them a chance to do their thing. Thank you.
And I think the other population that we think about, and certainly I've been seeing more in my practice, is migrants and newcomers. So I'm going to hand this over to Dr. Tremblay.
So I'm going to talk to you about a woman I've been following for the last year. So she's in her 30s. She's from Haiti, but she went through the migrant route through South America, North America, entered through Quebec, ended up in Montreal, and ended up straight to the hospital where she was diagnosed with HIV and diagnosed with an invasive endometrial cancer, metastasis everywhere. She has 2 tiny young children. So of course we started the treatment. We started HIV treatment, bictegravir, anthracitabine, and tenofovir, and acrylamide. And there was a discussion about chemotherapy because she was in such a bad state, whether it should be palliative care or whether we should try to do something. And it was decided that let's be aggressive and try to do whatever we can. So she underwent chemotherapy. In a lot of pain, and a lot of physical pain, and pain from not being able of seeing her children. So this is one example, but we've been seeing tons of these patients in the last year and a half. Just the number of migrants who have tested positive for HIV, these are data from 2021, was increased from 2020 to 2021, 16%, and it was during COVID time, so there was less diagnosis being done. And 30% of people who tested positive for HIV in 21 were migrants. So there is an increased share of the HIV positive population from migrant communities. And in the Montreal region, we see, according to the exposure category, that the greatest increase is among people coming from a country where HIV is endemic. It's the blue line on the graph. And also we see an increase in MSM, but I'm not going to talk about this for now. So in Quebec, in 21, 17.6% of new diagnoses were people from endemic countries, and it also represented 60% of new diagnosis in women. In 22, in Canada, we saw an increase of 24.9% in new diagnosis, but in Montreal, there was an increase of 120% overall in new diagnosis, but an increase of 394% in the migrant population. So there is a phenomena occurring, and we need to address this and be conscious and try to understand what's happening. So what we've said before is when we linked patient to care, these people do as well as any other people. You know, they get suppressed, they get, the outcomes are as good. These are a few studies that were done several years ago, not better, not the good methodology, but it shows that this is the message. If you get them into care and maintain them into care, they will have good outcomes. But when you look at these data from 2020 in the cascade of care in Canada, I don't know if you can see, I have trouble seeing the little, but it's the third or the fourth column where you see the third column. In people coming from endemic countries, the problem is the first column of the cascade of care. So we miss the diagnosis, and they are diagnosed late in their disease, but once we put them in care, we can get them suppressed. So what are the challenges? The underdiagnostic is a real challenge. They present with low CD4 counts, sometimes 0 CD4, 10 CD4. They have all of the opportunistic disease that we used to see in the old days, unfortunately. And you know, 31.9% were with advanced infection. So what's the problem to access to care? Well, the social challenges, of course. Housing is a major issue. This patient I was telling you about, we couldn't send her home. She had finished her chemotherapy that needed her to stay in the hospital. She was still very weak and in pain and neutropenic, so very dangerous for her to acquire infection, because her home was such a lugubre apartment that had cockroaches, everything. It was insalubre. I don't remember the word in English. But the social worker didn't want to send her home. And at the hospital, we want to discharge everybody, so we never want to keep anybody at the hospital. But they didn't want to send her. But she wanted to be with her 2 little children. Prognostic is not good from her cancer. She's going to die soon. So she wanted to be with her children. I wanted her to be with her children. What can we do? So we had to put the entire team of social work to try to find her a new place to live. Nothing was available. So what we had to do was to take an inspector from the city of Montreal, go and visit the apartment so that they can issue an order that she needed to have another apartment for. But it took like several people, a multidisciplinary team of people dedicated just to find a solution for this particular patient. And this is not available to all clinics, unfortunately. So housing, financial situation, problems with insurance. In her case, the migrants who are illegal refugees, or they don't have the status yet. It can take them 9 months until the federal government give them a status and permit, and they can get insurance, social insurance. They don't have any money. So, of course, the hospitals, they make a bill, but they know they will never be reimbursed. We don't get reimbursed. So if they live in another area where there's not such facilities, they don't have access to care at all. And of course, the stigma and other held beliefs and cultural beliefs. But in this case, it's not, they want treatment. They wanted treatment. So that's the situation, several challenges. It's a new phenomena, and we need to be very aware that it is ongoing and to try to find solutions with public health.
So I think, people are starting to respond already. What other underserved populations should be a focus? And I think, Black populations, new immigrants, Indigenous peoples, there's youth on there, and also children transitioning out to the adult system, which I think, I'll speak for myself, I think we're really bad at. When children are transitioning into the adult system, ACB youth, Black women, Indigenous individuals, trans individuals, although, there's some, certainly in some places there's good trans health care. In a lot of places in Ontario, they either don't exist or they're not connected with HIV services, so it can be quite difficult in terms of medications. Older adults, so half of my clinic would now be considered older adults, and I don't think we have really good resources for people who are aging. That's still a challenge that we see. So, we've talked, I think there's been a lot of bad news, or a lot of challenges in this, but I think, there's lots of good news as well, and we do have a lot of progress that's happening. So I'm gonna hand it over to Vimbai to talk about some of the progress and action that's happening.
Okay, so I'm going to bring it back home a little bit. I do echo a lot of things that I've heard today from each one of you. So I'm going to talk a little bit about Regional HIV/AIDS Connection, which is the ASO, so the AIDS Service Organization in which I work for. This is the regional AIDS service organization here in London, Ontario. And we provide services to regions, Middlesex, London, Huron, and beyond, and Perth, I believe. And basically the services that we have as an agency, we've started from a point of advocacy. So this agency, we've been around since 1985, I believe, so before I was born. I'm aging myself. But when I look at the work that RHAC is doing today, I look at how it has evolved from the 80s. And when I look at where we're at right now, I think that Regional HIV/AIDS Connection works to really advocate for policy change, to really meet our services with the demand that we see currently within our region. We've been a strong advocate for anti-oppression, greater involvement of people living with HIV, meaningful involvement. And I think because we're also a volunteer-driven agency, we have a lot of community mobilization that happens. We couldn't do all this work without our partners. So we have some amazing partners. We work closely, and I'll talk about our partnerships in terms of our location, first of all, because when I look at HIV care and connecting people to the services that they need, it makes a big difference when everybody is in a location that the person that is coming in for that service can access at once. As I mentioned before, what does it take for somebody to get to an appointment? Imagine having all those things in one place. I'm not saying we've perfected it. We have a very long way to go, but our community partners are super awesome for the work that they do. So we partner with our local CHC, London Intercommunity Health Center. Together we do prevention work as well. And then in our location, where we're located at 602 Queen Street, so we have 3 locations. One location is harm reduction services, where we have a safer consumption site and a needle exchange program. And then we have our second site, well, not second, but another site, which is the John Gordon Home. So historically, this location was, it was a palliative care home. Because HIV has not looked like AIDS, as I spoke about the faces when I began, we haven't had much of that, so it's been more of a transitional home for folks who are unhoused, who are transitioning into homes, and we try to get them set up with programs so that they're set up well and in a good way for when they leave the home. Where our headquarters is located, we have London Cares there. We also have OHAS, which is the Ontario Aboriginal HIV/AIDS Strategy, our very, very close partner. And together we try to work to, not try, but together we work to provide services and remove some of those barriers that we see for Indigenous individuals. We also have Sisters of St. Joseph's, which is, there is a cafe that's on site that makes sure people are fed, people who are unhoused, even those that are underhoused. So there's many services in our location. But other partners have started coming into that location, sort of a setup for that wraparound holistic care that we talked about before. Because of our partnerships, we've been able to do some groundbreaking stuff. So we've started a project. It's a 5-year project, and under the funding of public health, we were able to develop a program for sex workers called the Sex Workers Initiative for Safety and Health. And this is in partnership with a drop-in center called Safe Space and a Housing First-led agency called SLOAR, which is part of CMHA. And we've seen amazing things happen. In the first year, before the first year lapse, we actually saw a connection of over 155 sex workers. And I'm glad to say that in the second year, it's doubled. Just people accessing services, prevention, STBBI testing. Yeah, and also, so I'll talk a little bit about SWISH. Our program is frontline based, but we also do a lot of community building. Often I think sometimes with partnerships, it's assumed that everybody's knowing, like our goals are the same, we're going in the same direction. However, because the work we're doing, especially frontline work, it's often in the moment work and it's very fast paced. It's very easy for a lot of information to be left behind. So we have pieces of that capacity building that's done. We've actually had other cities ask for the model of SWISH just because of the impact it's had on not just London, but the surrounding areas. At Regional HIV/AIDS Connection, we have programs such as education, so that capacity building as well. We have educational initiatives. So we work together again with our partners to make sure that those gaps are being filled. We advocate with our partners as well, which makes a good case for us in terms of like when we're looking for fundings. We so often are short of resources and funding that we work with others and see how we can provide for those gaps. We have peer support programs which are led by people living with HIV, and they're developed. And I think it's, as I mentioned before, great involvement, meaningful involvement of the people that are accessing this service is integral to everything we do. We have community outreach as well. So we actually have mobile buses that drive around the region every day to make sure people are getting the things that they need, be it harm reduction supplies, be it that capacity building in terms of resources. Yeah, and we also do a lot of trainings for partnering organizations, but also for people that are providing services. I can't tell you how many capacity building sessions I've gone to talk about some of the things that could, some of the challenges that somebody could incur when trying to access care to nurses. And so it's something that we take pride in, but we're always open to build that capacity. At RHAC, we have a commitment to inclusivity. So our doors are open to anyone, regardless of what your background is. We try to make sure that if we don't have the service that somebody is accessing, we make sure that they leave with something that gives them hope. I think it's something that we always think about our value statement, which is the courage to do what's right. Often after giving that service, even when you've said to somebody, there's really nothing I can do and there's probably no resources, having that courage to look for the things, who knows, the next person, you might know those resources based on that person that you told, I don't have anything. So we do try to exercise that value statement. And at RHAC, I think that we find that our programs, as I said, are current, so they suit the current demand. The flexibility in which we work is almost puzzling to me how we do it. Because what often happens is sometimes we'll see that community partners or ourselves have had cuts in funding. And immediately we have to be flexible enough to maneuver in ways that we can navigate things for folks so that they can still access what they need to access.
So we're getting to the end, so everyone can yawn a little bit, but I think what we wanted to do at the end was think about a call to action, and I'm going to poll everyone on the panel. if you only had one thing that's going to advance us in terms of those goals that we have, the 95, 95, 95, but also just how we're going to get there, what would be the one thing? And remembering, we're talking about people at risk for HIV being connected to services for HIV prevention, people who are living with HIV knowing that knowing their HIV diagnosis, being connected to care, and then being virally suppressed. So what are the areas that we need to focus on over the next coming years to really achieve that zero compromise and to get to those goals? So we'll start at the end with Morris.
I think we need to live and believe in no more excuses. No more reasons why we cannot provide care, why we cannot engage certain populations, and why we can't step up to the plate. And I truly believe if we started thinking about what can we do instead of how it can't work, I think we can make the difference.
That's awesome. As the non-physician on the team, thank you, physicians, for your stellar work. Mind you, I hope we never compromise on the multidiscipline approach to HIV care. I think there are many nurses, psychologists, social workers, pharmacists, et cetera, and community-based organizations and people in this room that add so much to the care, the holistic care to HIV patients. So I hope we never compromise on that incredibly beautiful model of care that's been set up in the field of HIV.
For me, I think one of the things that I constantly see, having the misfortune of living in Ontario where we don't have good drug access, is the uneven access across the country to both HIV prevention and HIV medication, HIV care. Depending on where you live, if you're in BC, you can get your medications relatively for free for most people. If you're in Ontario, it can be quite difficult for individuals to access medication, and I think that's a major challenge that hopefully we can work on over the next few years to really make that access equal across the country, but just easier for people to get both prevention and HIV care.
For me, it's the necessity to continue research. In Quebec, the HIV/AIDS network just saw its funding completely cut by the FRQS, which is the agency that administers money for research. So they just cut us dead. It had been existing for 35 years. In Canada, I am concerned that by writing a framework on STBBI research, there is a danger that the research specific to HIV be diluted because we don't necessarily address similar population, and I'm afraid that we're losing the priority that was given to HIV research before. And this is a movement everywhere. So HIV is no longer in at the front scene of research, although HIV research has allowed so many advances that have been used in the COVID epidemic, in other fields of medicine. But there is a real tendency to decrease the amount of money and the interest in HIV research. And it's in all its sphere: community research, social research, basic science, clinical research, implementation science research, which is totally important because we have tools that we don't know how to use properly. So for me, that's the call to action. Continue to do your research, but also to do pressure on the governments so that they can still see HIV as a priority, which they don't presently.
I mean, you said one thing. I could be here all day talking about all the things. For me, we need funding. I know it's about the money and what have you, but we need funding that's meaningful. Not funding that is rigid and doesn't focus on the things that are needed to be done. We need as much funding as we can for people to be able to be involved in their health care. We need funding that is not oppressive, is accessible to everybody. So that's what I'll finish off with today.
So, there's lots of calls to action, but I think that we need to look at all different aspects if we're really going to achieve that idea of zero compromise in HIV care and HIV prevention. And so, first of all, I want to thank everyone for their attention, and for coming out and staying with us after the wraps were over. We're very happy that everyone stayed with us to talk. And we do have a few minutes to open it up to any discussion points, things that people wanted to bring up, questions they had. I think we have a microphone in the middle of the room now. It's there. So if anybody has anything that they wanted to bring up or ask, just feel free to walk. I see you're waving. Just walk to the mic. It's right there. I think. I can
Yes.
barely see it. But yeah.
Okay. Good afternoon, everyone. My name is Anita Ikwe, and I work in Women's Health and Women's Hands Community Health Center, Toronto, as the system navigation, the system navigator. It's a SNAP project. It's basically HIV system navigation. So I work with young women like myself living with the HIV, help them navigate the system, especially those who are new to Canada, trying to find their way around. Like the health, trying to connect them to family doctor. If they need psychosocial support, we do referrals and, food bank, clothing and all of that. So yeah, so that's by the way though. My first, I wouldn't say it's a question, it's kind of like an urge, like just to urge you, like, okay, you're doing a great job, you're doing a fantastic job, thank you so much for all of those breakdown, it's really helpful. But is there a way you guys are making universal medication accessible to, accessible to everyone regardless of their Canadian status, be it refugee, or your PR and stuff. I'm still a refugee claimant. I stand for a migrant. I stand for refugees that are still trying to get their papers in Canada. And it's very hard for some persons. They come in, you can't afford to, pay for the medication. How can they access? I know Women's Health is doing a very great job, fantastic job. Since I came into Women's Health, I've not paid anything. I literally, even the what's it called? When I go for blood works, they literally attached, the payment papers, so I don't pay anything. But what about those people who, they're not, they've not walked their way into a facility like Women's Health yet? How would they reach? How would they be able to access this medication without having to pay a dime? And yes, that's one. And also acknowledging the role of peers in engaging people living with HIV is really very key. And the last but not the least is the stigma. I could literally stay here and talk about this for the entire conference. I wouldn't end. I wouldn't stop talking, but the little time I have, I'll just have to air myself out. So I left Nigeria and my country home, coming to Canada to live a free life, free of stigma, free of discrimination. And there is this, I don't know, like you were talking about, this is literally the medical aspect, right? And we have a long way to go, trust me. Even though a lot has been done, we still have a long way to go. This is the medical aspect now. We're not talking about like the advocacy aspect, the aspect where everybody is comfortable and living freely, regardless. If you want to disclose, if you want to live openly or, I've had series of experience, and that's why I'm talking about it. I'm boldly talking about it today. Because I came into a space where, we have this set of people who are, it's okay, it's totally fine. I was in that position too. That position where I cannot come out and say I'm living with HIV. That position where I cannot, trust anybody with my HIV status. Disclosure was a problem. Everything was a problem. I was once there. It's totally fine that some of us can't talk about these things, right? Also, why I am not stopping you from not coming out, right? I'm not stopping you from still trying to get out of that space. So why are you stopping me? Why are you stopping me? Those of us who are like, for example, I could say a lot of stories, but I would just make mention of one. You know, like, I found myself in a space where I'm meant to confine to everybody's will of, oh, we don't want anyone here to know that we are living with the HIV, you know. Maybe if I'm putting on a shirt that has to do with living with HIV, and you're telling me to, you know, pull off such shirts, and because everyone here is not comfortable, what about me? We're trying to end stigma. What about me? I am so determined to end stigma, but you're pulling me back and not wanting me to, you know, keep up. I feel very sad with all of this. Before I end this conversation, anyone here, I am willing for it. I'm open to any opportunities, media opportunities, talking on space. I am openly living with HIV, and I vow to stop the stigma. I vow to end the stigma, you know, related to HIV. I lost my father from AIDS. So I owe my father a mission. I was born with HIV. I'm 26 years old. My father died of AIDS when I was 4 years old. I owe my father this fight. I owe him ending stigma, end AIDS, make sure that everyone living with HIV can freely walk around and know that, you know, the next person know that they're living with HIV and there is nothing. But that is one thing, and the next thing is me finding myself in a space where I am supposed to, oh, Canada has different laws. Oh, don't take pictures of yourself when you're sitting around people living with HIV. Like, I am taking pictures of myself. It's a problem.
So thank you. I mean, I think one of the things that you brought up is that resonates with me again is that idea of stigma in medical spaces. And, you know, we're probably preaching to the choir here a little bit. You know, it's the people who are in the room are already people who are working in HIV and working to destigmatize, but really getting that message beyond just the HIV providers. Mm-hmm. You know, and I think the other part that resonated with me because of working in downtown Toronto, where we're seeing a lot of migrants, that medication coverage issue is really important. Now, a lot of it, I think, is that connection to care piece, and you were talking about some of those wraparound services. What I always say is, if somebody gets to me, I can figure out how to get them medications, but it's that newcomer to Canada who may not know where to go, who may not have access to the services, and how do we do a better job of connecting that person to care so that they can actually access their medications for free, because there's lots of ways to do that.
I want to thank you, my sister, for coming up. You know, as somebody that came here as a refugee as well, I felt your passion. Before we even start to talk about accessing service or that medication in terms of HIV, there's so many layers. You enter this country thinking that you're going to have services. You hear about the services that are there. Accessing them, you're met with racism.
Yeah.
You're met with sexism. You're met with ears that won't listen and are telling you things that are so clinical that you can't understand. You can't make informed decisions about your own health care. I think for us, the reason, for me, I actually got a lot of service navigation from an AIDS service organization, accessing prevention. And I remember, and I believe he's here somewhere, Johannes from APA. He said to me, if you don't come, I won't know what you need. So I think as immigrants to Canada, as refugees, we need to encourage each other and make sure the word is out. There's nothing that works as powerful in our world as word of mouth. Because when we're not spreading that word to us, there are people that have been doing undercover work. I've known nurses, I know that there's some that are here without saying too much, that are doing work to make sure that people access things, even if they're undocumented. Making sure that they not access only HIV care, but other things that they need. That work is being done. For reasons, I think also with that funding that I spoke about, there's not enough money for them to get the word out there. So I think everybody in this room has that piece to play to make sure that we're spreading that information. And yeah, I would like to connect with you after this so that we can talk about some of the ways that we've been able to system navigate for immigrants. We've had a large influx of people coming to our city being told that we have all the services, only to get here and be disappointed. So I think when we collaborate like that, there's a lot we can do.
So we have 1 more minute, and then I think we have to go. So we'll open up for one more person.
Good afternoon, everybody. Bon après-midi à tout le monde. My name is Chantal Mukandoli. I come from Toronto. This is my first time I come to London, Ontario. I work with Women Health Community Center as a peer ambassador to distribute HIV self-testing kit and to help women in the communities. So for me, it's not a question, it's a comment or recommendation. I hear all the presentation. Thank you so much. And thank you so much for all the researchers. Thank you so much for all the doctors, the students. Thank you so much, especially my doctor. My doctor is Dr. Mona Lofty. She helped me a lot. Without her, we not even have a life. I hear you talk about treatment. Yes. Talk about housing. Talk about stigma, culture, immigration. I know one thing I wanted to ask, please, I know here there is a funders, there is a policy makers, there is a researcher as you are here, service providers. Please, we need funding. We need peer, second hand, to help the organizations. Please, I know you hear this voice. Because a peer, we need a peer in the organization to help even the researcher, to help even the service providers, how to help other people in our communities, Francophone. In Toronto, we don't have a funding to translate the research. Is it not a lot of money for the research? For people, they deny to participate in the research because of what? There is no money to give people to participate, to give you information. Please, and then what things I wanted to let you know. Collaboration with the organization, with the communities, that will make you to have some people to participate in the research. Thank you so much.
And I think Dr. Tremblay, you spoke to that about funding being cut. And, and I think that by the end of our talk, it was funding. I think we're all, no matter where we are, we're feeling some of those cuts that have happened. And all of us in the room can play a role in keeping HIV research front and center, HIV care front and center. Because I don't think the government's really going to be that excited about funding it, so we need to keep pushing for that to happen. And I know, Morris, you talked about that as well. I think we have one more person.
My name is Jay McGillivray, and I've been working in the field since the mid-'80s, and now work with Dr. Mark Uden in Toronto running the Positive Pregnancy Program, and we've been doing that for decades. I think we've had 2 positive babies out of hundreds of families. and that is because they did access care. The first speaker talked about women's health in women's hands, which is a community center, a community health center for racialized women. And that this service navigation that they can do for folks who are newly arrived in Canada is so essential because it doesn't happen otherwise. But it's stigma that drives the lack of access to care. From my perspective, I'd say 90% of the folks that we see are newly arrived in Canada or have been here less than 5 years. And they find us through the police. Sometimes they are from the customs folks or the border folks, but primarily, like you were saying, word of mouth or women's health in women's hands. Why aren't there big billboards when people arrive in Canada saying you are welcome here? If you have HIV, you are welcome here. And here's where you can go. Like, it should be part of the welcome package. That reduces the stigma because everybody universally gets it. You don't just give it to individual communities. And that's part of what it is. It's that segmented approach to access. You have Indigenous folks, you have people of color, you have trans folks, you have women. And I have to say, there's remarkably little representation about women in research here. There's not a lot about the women's community, what's happening, what works. There's so much strength in the women living with HIV here in Canada. They have so much to offer, and they should be such an enormous part of this. So I'd love to know what the percentage of research in the, let's just say, abstracts was devoted to women versus everybody else. It looked to me to be incredibly small. And I think if you're going to be talking about the next generation, that's women. As women and their children. And they need to access care regardless of who they are. It's finding ways that we inadvertently stigmatize, even ourselves as providers, inadvertently stigmatize access. And I think that's an enormous thing. So I think asking the people in the positive community how to do things is probably the best way to go.
I love the idea of a billboard. I think we were actually having this discussion with some folks in the OHTN a little while ago, because we are seeing, new diagnoses amongst newcomers as well as people who know their status but don't know how to access care.
Yeah.
And that idea of at the airport, it's here's a QR code, scan this is all the places you can go. Because when I see folks in clinic, I'll often ask, how did you hear about us? And it's almost always word of mouth, as you say. Yeah. There's no official person saying this is where you can go.
Nope.
And that support from government, this would be Immigration Canada, right? Like, here's a sign in the airport. If you're living with HIV, go to this website and it's going to tell you who the ASO is in your city, how to access medical care, all those things.
But I would say that billboard be prominent, not a QR code. You reduce stigmatization if you say it out loud and everybody sees it. So yes, a QR code is
so they
great.
can get to the website, but still
that
having
they
it
can get
out
to
there.
the website, but welcome. You are welcome here.
Yeah, it's a good
Anyway,
idea.
that's my bit.
Thanks, Jen.
So there is a post-event survey with a QR code. So if everyone can take a look at that and give us just feedback on the session, it'll help to shape future symposia. And again, I just want to thank everyone for coming and your attention and obviously for your passion on this topic, as I hope everyone realizes that we're all passionate here about it as well.
Thank you.
Now you clap for us.
Good job, Ken.